Good evening, everybody. I am Dr. Sai Chandar, pediatric neurologist, at present practicing in Hanampanda, Telangana at my center, that is Dr. Sai Chandar Child Neurocare. Today, I am going to discuss very common topic and most common neurological disorder, that is the febrile seizures. So, febrile seizures is the most common neurological disorder of infant and young children. So many parents have experienced this situation in their children, and this will cause more stress and tension among the parents. So it is a age dependent phenomenon, means it is affected in the certain age group of children, that is especially in 6 months to 60 months of age. So even though they in children have multiple episodes of seizures, but this is not considered as the epilepsy. So in this topic we can discuss about the what is the febrile seizures, how many types of febrile seizures, so what are the risk factors for further seizures or epilepsy, and how can we prevent these febrile seizures? How can manage these seizures? What investigations we are going to do during these febrile seizures? So febrile seizures. What are the different definitions? So different organizations or association given different definitions, but in all these definitions we have the some common points only differ in the age group only. So according to National Institute of Health, so according to this, it is an event in infancy or childhood, usually occurring between the 3 months and 5 years of age, associated with fever, but without evidence of intracranial infection or any defined other defined cause. So this is the definition given by the National Institute of Health. After that, International League Against Epilepsy given one definition in 1993. They defined these febrile seizures, a seizure occurring in childhood after age of 1 month, associated with febrile illness, but this is not caused by the infection of CNS or any previous history of neonatal seizures or any previous unprovoked seizures, are not meeting the criteria of other acute symptomatic seizures. Means acute symptomatic seizures means any hyponatremia, hypoglycemia, trauma like that. So this is not going to meet this criteria. So here the lower age limit is 1 month, except the neonatal period they consider they taken as the one month period taken as the lower limit. While in case of NIH, 3 months is the lower limit of the age for febrile seizures. So recent definition by the American Academy of Pediatrics, they defined as that this is the seizure occurring in febrile children between the age of 6 to and 60 months of age, who do not have intracranial infection, metabolic disturbances, and history of febrile seizures. So in all these three organization definitions, so there is no intracranial infection, there is no metabolic disturbances, and there is no previous history of febrile seizures. So that may be neonatal seizures or any febrile seizures. So age limit is least age limit is 1 month by the ILAE. So whatever these associations given the definitions, but generally accepted criteria, most widely accepted criteria is these five criteria. One is a seizure associated with an elevated temperature that is more than 38 degrees centigrade, and age limit is 6 months to 5 years of age, absence of any CNS infection or inflammation, absence of acute systemic metabolic abnormalities, that is hypoglycemia, hyponatremia, right? No history of previous febrile seizures. So these five criteria need to fulfill for define the febrile seizures. So what are the incidence and prevalence of febrile seizures? What are the common age group in the febrile seizures? We can discuss. So in the white population, 2 to 5% of children have these febrile seizures. Coming to the Asian population, 8 to 10%. In India, especially in our locality, that may be 15 to 20% of children have the febrile seizures before the 5 years of age. So age is the very important in febrile seizures. Already we mentioned about the age dependent phenomenon. Age of presentation may be variable. So from the 1 month to 8 years of age, children can have the febrile seizures, but 90% of children have their first episode of seizure before 3 years of age. So 90% of children before 3 years of age. Most common age is 1.5 to 2 years of age. Only 6% children have seizures before 6 months, and 3-4% have after the 3 years of age. So at 8 years of age also child can have the febrile seizures. So there is no female and male differentiation which are more affected. There is no sex predilection according to the studies. But in some kids, Their first episode of febrile seizure, they can present with the status epilepticus. That is called febrile status epilepticus. So that is in 5 to 10% of children have the febrile status epilepticus. So what are the types of febrile seizures? There's two types of febrile seizures. Is there? One is simple febrile seizure. Second one is the complex febrile seizure. So other terms using we are seeing on the prescriptions: typical febrile seizures, atypical febrile seizures, fever-triggered epilepsy, febrile seizures alone, simple febrile seizure plus. These are all the confusing words and confusing terminologies. So we are not going to use these confusing terminologies. Recent 2021 AOCN and IAP released one consensus about these terminologies. Only use the words of simple febrile seizures and complex febrile seizures. We are going to see what is the meaning of simple febrile seizure and complex febrile seizures. So simple febrile seizures are most common type. So semiology of seizure is generalized seizure that will subside within 15 minutes of time, and within the 24 hours they are not going to recur. We are coming to the complex febrile seizures. 20 to 30% of children have the complex febrile seizures. Focal onset, so one side, right side or left side, any side, and more than 15 minutes, they can recur within the 24 hours of 24 hours. So any child with fever at 2 episodes of seizures within the 24 hours, we can take as the complex febrile seizures. Any child have single episode of seizure more than 15 minutes, that may be generalized focal, we can taken as the complex febrile seizures. Any child have fever with focal episode of seizure, we can take as the complex febrile seizures. Because simple febrile seizure approach and complex febrile seizure approach is little bit different. That is we are going to see in next slides. So what are the risk factors to get these febrile seizures? Most important risk factor is age. Age itself is the risk factor because these less than 5 years kids, there have some different mechanisms to protect against this fever and interleukins. So that's why age is the most important risk factor. Temperature, high temperature, that is the maximum height of the temperature is the important risk factor. Not the rate of the rise of the temperature is not the risk factor. And next is the infections. Viral infections are more risk for the febrile seizure compared to the bacterial infections. Common viral infections are HHV6 and influenza, respiratory syncytial virus, and adenovirus, herpes, and HHV7. So most of these febrile seizures are associated with respiratory tract infections and gastroenteritis. Immunization, we can see these after post vaccination like DPT at the time of 10 weeks and 14 weeks and 18 months, and at the MMR vaccine at 9 months, they can have the febrile seizures at this age. This is also some risk factors. And iron deficiency anemia is associated with most of these febrile seizures patient. With the supplementation of iron, so we can reduce the recurrence of febrile seizures. That is well known fact. So, and last one important one is 25 to 40% of children, febrile seizure children have the family history of febrile seizures. So there is genetic susceptibility is there. So they can run through the families in the autosomal dominant pattern and sometimes in polygenic patterns. So recognized identified genes on chromosome 2, 8, and 19 is there. Some genes are SCN1A, 1B, and GABRG2 genes also identified in for this febrile seizure spectrum. So these are the risk factors for febrile seizures. So if any child have the febrile seizures, is this seizure or not? What is the cause for the seizure? We need to identify. So first is the seizure, febrile seizure mimics. We need to identify. One is the rigors. So during the high grade fever, child can have chills and rigors. These are also mimic like febrile seizures. So many has misinterpreted as the febrile seizures. And febrile delirium. Chill with high grade fever, children will have some confusion state and irrelevant talk and altered sensor. This is also they can consider as the febrile seizures, but we need to differentiate between a febrile delirium and febrile seizures. And febrile syncope. With high grade of fever, children will they have the loss of consciousness. That is the febrile syncope. Other different mimics are breath holding attacks and reflex anoxic seizures. And these febrile seizures may be the starting point of the evolving epilepsy syndromes, or maybe the some central nervous system infection. So these are the differential diagnosis of febrile seizures or febrile seizure mimics. So how can we differentiate what are the dangerous facts and what are the red flag signs? We are now going to discuss. So during the workup of febrile seizures, very important is the history. History is the very important. After that, some examination and investigations will help. So febrile seizures is the diagnosis by exclusion and history. So these seizure onset along with the fever or after the seizure, sometimes the fever is happens. That's a very important point. And how many episodes of seizures is there? Immediate after seizure, what is the sensorium level, conscious levels are very, very important. In febrile seizures kids, somehow the rise of temperature, seizures with that is for 5 minutes. After 5 minutes, child become normal. So that is the classic febrile seizures history. And if in case of complex febrile seizures, they can have the 2 episodes of febrile seizures within the 24 hours. And we need to ask about the any drug intoxication. At the same time, find out the cause of the fever. That may be cold or gastroenteritis, rash, etc. And very, very important development of the child, family history of the child, that will give the clues about this febrile seizure, or we are going to dealing with the other chronic neurological disorder like that. And any previous history of febrile or febrile seizures and neurological problems, we need to inquire during the history. And examination, dysmorphic features and failure, and any CNS, that is especially meningeal signs to rule out the CNS infections. This is the minimum workup and minimum important points during while we are approaching the febrile seizures patient. So what are the red flag signs? If any child came to our ER or came to our OP, so you are not going to directly tell this is the simple febrile seizures. There is no need to worry. We need to concentrate on some things. So to prevent the damage, further damage, and go to the further appropriate management. These are the red flag signs. If any one of sign is there, we need to concentrate and we need to take action appropriately. Any meningeal signs like neck stiffness, or Kernick sign or any Brzezinski sign is there, we need to think of CNS infection like meningitis. So after the febrile seizures, there is post-ictal drowsiness is very, very less time. So if any child is not getting the consciousness over the 1 hour after the seizure or altered sensorium after even 1 hour after seizure also, we need to consider and think of any some other causes of acute febrile encephalopathy causes. And evolving rashes in unwell child like meningitis, the meningococemia, we need to think of this. Any rashes in sick child, we need to think of that. Any bulging AF, that is itself indicates the raised ICT is there. Tachycardia out of proportion of body temperature, we can see in sepsis child. So think of the sepsis and any signs of heart. These are the red flag signs. We need to take the appropriate action, proper action to protect the child. So these are the red flag signs. Remember, while we are seeing the any febrile seizure child. So lab investigation. So rule out the acute metabolic causes like hypoglycemia, any hyponatremia, hypocalcemia, hypomagnesemia. Go to the glucose and these investigations and find out the cause of fever, CBC, CRP, chest X-ray. According to the history, we can go for the appropriate investigations. And 3 more investigations: CSF analysis, EEG, imaging. These 3 important investigation in case of febrile seizure child, when we need to do, when we are not going to do, that is important points. First, the lumbar function. So routinely, we are not going to do the lumbar function in simple febrile seizures patient. But when we can do the lumbar function, so according to American Academy of Pediatrics, any signs and symptoms suggestive of possible meningitis or other CNS infections like Kernick sign, neck stiffness, or any raised ICT signs like bulge AF. So we are going to do CSF. And if child before 12 months of age, we don't know about the immunization status. In that child, we are going to do the CSF analysis. And the child is using outside or anywhere some antibiotics, we can use do the CSF. And any child with febrile status epilepticus, compulsory we need to do the CSF examination. And second day after the 24 hours of the fever onset, we need to go to the CSF analysis. So these are the 5 points when we are going to do the CSF analysis in case of simple febrile seizures or any febrile seizures. Second investigation is EEG. So routinely EEG is not recommended for simple febrile seizures or complex febrile seizures. Only indication of the EEG is prolonged seizures. So if the child had 2 episodes of small 5 minute seizures within the 24 hours, that is the not indication. But prolonged seizures like more than 15 minutes or febrile status epilepticus, that is the indication. Abnormal neurological status, continuing abnormal neurological status, any previous episode of febrile seizures. So these 3 conditions are indications for the EEG. So which time we need to do EEG? So this is the common question while I am discussing with some my colleagues. So if febrile seizures is there, when we are going to do EEG? Some textbooks given 2 weeks after the febrile seizure. Some textbooks given one in the immediate day. But there is optimal timing of EEG is not yet well defined. But within the 72 hours, if indication is there, we do this EEG within the 72 hours. That is useful for prognostic purposes. So one more investigation is neuroimaging. So common question: MRI is better or CT scan is better? In which patient we need to go for the MRI or CT? So routinely, in case of simple febrile seizures, we are not going to do the brain imaging. So indications are urgent indication is when there is we are suspecting some meningitis, that is CT brain with contrast or MRI. Any abnormal head sizes, we are going to do the neuroimaging, and persistently abnormal neurological examination. So continuing altered sensorium is there, continuing some abnormal focal seizure with Todd's palsy, continuous Todd's palsy is there. We are going to do the imaging. Which is best, MRI or CT? MRI is the always best, better than the CT scan while we are approaching the febrile seizures cases. So MRI indications of the MRI: prolonged focal seizure, developmentally abnormal child, any previous history of previous febrile seizure. These three conditions are we are going to do the MRI brain in the any patient presented with the febrile seizures. So these are the indications and indications of these three neurological investigations like lumbar puncture, EEG, and neuroimaging. So after this imaging, after this approach, we are going to treat the child. How can we manage the child? So this is in the four parts. One is the emergency rescue therapy and fever control and prevention therapy. And when child have the seizures, we need to counsel the parents. We need to teach the parents to how can they take care of home or pre-hospital therapy. So rescue therapy. When most of the patient, when they reach the ER or hospital, they are in the postictal stage or they are completely normal sensory, but they can have the mild fever. So at that time, there is no need of any benzodiazepines or any rescue therapy. If when child reaching the ER still seizure is there, we are going to do the IV benzodiazepine. So that may be diazepam or lorazepam. Lorazepam is better according to the studies. So if seizure is continuing even after 10 minutes of first dose, we are going to the second dose. So even if that is after that also continuing, we need to follow the status epilepticus protocol. According to the protocol, we need to give the medications. If there is no IV access while child reaches the ER, we can use the intramuscular midazolam or nasal midazolam or rectal diazepam or buccal midazolam. This is the emergency rescue therapy in the ER. So next step is the fever control. So for the fever control, one is the hydration is the very important factor. So immediately in the air we can use the rectal PCM or oral PCM ibuprofen. Combination therapy is not that much effective. So try to avoid the mefenamic acid. Mefenamic acid can decrease the seizure threshold and that can further risk factor for the febrile seizures. Next. So after that, preventive therapy. So this is the very common question. So many doubts is there among our colleagues and our friends also. So these anti-seizure drugs can reduce the risk of recurrence. That is sure cut. Anti-seizure drugs can reduce the risk of recurrence. But when we need to use these anti-seizure drugs continuously, chronic usage. So, but due to the benign nature and not advisable, because of the benign nature and with the risk benefit ratio, routinely not advising this anti-seizure medication. But when we need to advise, what are the indications? That is, any child have the febrile seizures with the febrile seizures. First episode of febrile seizure is there. Now febrile seizure is there. We can advise the anti-seizure medication. Recurrent febrile status epilepticus. Any child have the 2 episodes of febrile status epilepticus, we need to advise these chronic anti-seizure medications. Alternate focal seizures. One time, one left side focal seizure, second time right side focal seizures. We can advise. And very frequent febrile seizures. That means each time fever is there, that is seizure is there. So we can advise this chronic anti-seizure medication. But this is individualized. That is based on the risk factors. What are the risk factors I am going to discuss? So, which is good? Intermittent anti-seizure medication, continuous anti-seizure medication. According to Campion-based study, up to now there is no difference is there to prevent the febrile seizures. But due to the parents' anxiety, we can advise intermittent anti-seizure medications. So, what are the drugs used for intermittent prophylaxis? One is rectal diazepam and clobazam, that is 0.5 to 1 mg per kg, or clonazepam. Up to now, dosage and duration is not evaluated. There is no randomized control trials on the intermittent benzodiazepine usage in the prevention of the recurrent decrease the recurrence of the febrile seizures. But in our location, very commonly using drug is clobazam, that is 0.5 to 1 mg per kg. So till the fever subside or 3 days. This is the usual dosage we are using here. Continuous prophylaxis. Which drugs is better? That is the phenobarbital and valproate and clobazam is the good drugs. Try to avoid the sodium channel blockers like phenytoin and carbamazepine. These are the sodium channel blockers, and this febrile seizures pathology located in the sodium channels. So that's why they can precipitate the febrile seizures. That's why try to avoid these medications. So if valproate is not effective, we can add the clobazam daily dosage also. And these medications can reduce the recurrence of febrile seizures only, but not going to reduce the chances of development of epilepsy. We don't know, right? So recent study from 2019, one Italian pediatric neurology association, intermittent melatonin can reduce the recurrence of febrile seizures. One more study is there. There is 2 weeks dosage of levetiracetam can also reduce the recurrence of febrile seizures. Is there. So during the fever episode, try to avoid the cold syrups, that is antihistaminics. These antihistaminics can reduce the seizure threshold and precipitate these febrile seizures. So try to avoid the antihistaminic during the fever. Any any child have the high risk factors for the febrile seizures. So, and fourth one is the home and free hospital management. So any child have the seizures at home, febrile seizure previously, now child has the fever. How can manage the child at home? So first thing is the control the fever. That is the utmost important thing. And second thing is the rectal diazepam or nasal midazolam. In our location, we are commonly using the midazolam spray. So that is we can available in two forms. What is 0.5 mg and 1.25 mg. I used to advise 0.5 mg. So dosage also very important. Less than 10 kg, 1 to 2 puffs in each nostril, and 10 to 16 kgs, 2 to 3 puffs, and 16 to 32 kgs, 4 to 6 puffs. So while we are advising these 2 to 3 puffs and 4 to 6 puffs, they are not going to give this much of puffs. So we need to demonstrate during our OPD, in the OPD, any child have the febrile seizures with high risk factors. So how to use the midazolam nasal spray, we need to demonstrate them. So use these midazolam spray use only if the seizures is more than 5 minutes only. We need to write clearly, very clearly, use the midazolam spray if seizures is more than 5 minutes, and write clearly, write 2 puffs in each nostril if seizure is more than 5 minutes. So we need to write these suggestions very clearly and demonstrate this very clearly, and use only one time. If seizure is not subsided after 10 minutes, use the second time while and start to the hospital. So next is the, so if febrile seizures is there, so many parents will ask, is my child get second episode of seizures? How many episodes of seizures? Up to how many years this child can get the seizures? Second thing. First thing. Second thing, this is this fits epilepsy or not? How many years we need to use this medication? So recurrence, overall recurrence is 1/3 recurrence is there. If any child have the seizure at any time, the overall recurrence is 1/3. 30 to 35% of children can have the second episode of seizure. Means remaining 65 to 70% of children don't have the seizures, right? So we need to tell clearly about there is 30% chance is there. So age is the main factor. So if the on first episode of seizure before the 1 year of age, there is 50% risk is there. So we know that if that is at the 1 year 30%, and 2 years first episode of seizures at 2 years, that is 10% of risk. More than 3 years, that is the 8% of risk is there. So at before 1 year of age, there is clearly you need to tell 50% of risk is there. So with that, we can prepare the parents to prevent anxiety during the next episode of febrile seizures like that. And what are the major risk factors? So you can tell this child have high risk for next episode of febrile seizure. This child have low risk for febrile seizure. So major risk factors is already we discussed. That is less than 1 year of age, and duration of the fever, and low temperature, low fever. Low fever is also associated with major risk factor. Minor risk factors of family history of febrile seizures, family history of epilepsy, complex febrile seizures, hyponatremia. In some guidelines, there is sex also, male sex have the minor risk factor like that, but these seven are the main most important risk factors, major and minor risk factors. So we need to calculate age of onset, duration of fever, and family history and type of seizure. We can counsel them. So your child have the high risk for next episode of seizure like that. And what is the chances of development of epilepsy if any child have the recurrent febrile seizures? Febrile seizures. This overall risk is 2 to 5%. That is 2 to 3 times higher than the general populations. So what are the risk percentages in different type of seizures, febrile seizures? Simple febrile seizures only 1%. Recurrent febrile seizures 4%, and complex febrile seizures 6%. So that is the difference. Simple febrile seizures to complex febrile seizures difference getting the recurrence and epilepsy also. And fever less than 1 hour before the seizures. So immediately onset of fever, if child have the seizures, there is high risk for the recurrence, that is 11%. Family history of epilepsy with febrile seizures, that is 18% getting the epilepsy. So neurodevelopmental abnormalities, any associated neurodevelopmental abnormalities now came with the febrile seizure. There is recurrence is 33%. So if any child with family history of febrile seizures and complex febrile seizures and recurrent febrile seizures, that is the high chances of getting the epilepsy. So many times they will come with 2 hours. So this will up to 5 years of age only. After 5 years, my child is not going to get these seizures. But you need to calculate, identify the risk factors, counsel the parents to prepare and about their anxiety. So these are the important risk factors, very useful during the counseling the febrile seizures. Because febrile seizures is the, we can think of this is simple, but parents' anxiety is more, and they can go through the 1 or 2 doctors when they have this type of febrile seizures. So now I am going to give 4 case scenarios, clinical scenarios, different between the simple febrile, complex febrile like that. So this is a 18 months old child with normal birth and development. Child had since one day child had loose stools and vomiting. So fever on that day 8 a.m. Seizure at the time of 12 p.m. So the seizure with fever, that is GTCF type and 3 minutes. No family history. When they reach the ER, child is active, stable vitals, normal neurological examination. Here, age of the child is 18 months and normal birth, normal development. Fever, after 4 hours of the fever, child have the 1 episode of generalized seizures and 3 minutes. This will give the simple febrile seizures. Age of onset is 18 months and there is no family. Only here, there is no major risk factors is not there. So there is only 30% of getting the seizures is there. We can counsel them. Right. This is a simple febrile seizures. This is the next clinical scenario. 3 years old female child, normal birth and developmental history. First episode of seizures at the 11 months of age. That means before the 1 year of age with upper respiratory tract infection. That is right focal seizures for 3 minutes. And second episode at 18 months. After 7 months of this first episode, that is also with upper respiratory tract infection. That is also focal seizures. So they started on clobazam intermittent prophylaxis. Third episode of seizure, that is also with cold, means upper respiratory tract infection. This time GTCS type, that is only for 1 minute. And fourth episode, thus this time also have upper respiratory tract infection, seizures with fever. So there is family history of JME is there. From 11 months of age, child had the 4 episode of seizures. 2 episodes are focal seizures, that is giving the complex febrile seizures, and 2 episodes of simple febrile seizures. And family history is there. So there is the recurrence, high recurrence chances is there. So we can counsel them, child had the complex and simple febrile seizures and 4 episodes, family history is there, and less than 1 year of age. There is high recurrence is there. When in these cases, when patients is very anxiety, we can start the chronic anti-epileptic therapy. Right. This is the third scenario. 2 years old male child with normal birth and developmental history. First episode of seizure is 3.5 months after the vaccination. So with the vaccination fever, after that seizure is there. That is 3.5 months. That is the GTCS type of seizure. Second episode at 6 months. So and after that, every 2 to 3 months, focal seizure, that may be right or that may be wrong. So with these seizures, child development is slowing. So what is this case scenario? Here, multiple episodes of seizures started before 6 months of age. That is also with vaccination and complex febrile seizures most of the time. So this is a special situation, that is a severe type of febrile seizure spectrum. That is the Dravet syndrome type. So we can discuss about Dravet syndrome separate in the separate topic, but we need to remember any child have the less than 6 months of age or 1 year of age and vaccinate post vaccination, we can call sometime vaccine encephalopathy, and after that during the each fever that child have the alternate focal seizures or seizures. So there is a very high risk and drug resistant epilepsy, they are going to develop the epilepsy, that is the epileptic encephalopathy, that is a Dravet syndrome. We need to counsel the parents, be prepare with this all these medications, and we need to start early starting the anti-epileptic medication in this case scenario. So fourth case scenario, 4.5-year-old man child, NICU stay for hypoglycemia is there, but normal development. At the 16 months of age, child had one episode of fever, that is at the fever and 3 a.m. seizure is there. So that is for GTCS for 5 minutes. After that, 23 months with gastroenteritis, fever, and at 5 a.m. again child had the GTCS 10 minutes. At that time started with clobazam intermittent prophylaxis. After that, 36 months gastroenteritis, fever, again seizure at 6 a.m. That is also GTCS. From 3 years to 4.5 years, multiple episodes of seizures. All episodes is in the early morning one. So almost all episodes associated with the fever, and after within the 24 hours of fever, child had seizures. All seizures in the early morning period started on valproate, but even after that also child had seizures with fever. So, but neurologically complete normal. From 16 months of age to 4.5 years of age, child had multiple episode of seizures with fever and GTCS type, but all are early morning. So here, this is, you can think this is simple febrile seizure or complex febrile seizure or something else. One clue is all episodes occurring in the morning time, and child have the neonatal hypoglycemia, and child have the fever and gastroenteritis. This is give the glucose. We need to check the glucose. So when child presented to us, we at the 8 a.m. when April this child came to us, we checked the glucose. Glucose levels are low. So we go through retrospectively during these all 4 episodes. 2 episodes are associated with low glucose levels. So and neonatal glucose. So this is the after that, after our evaluation, this is diagnosed as idiopathic pediatric hypoglycemia. So these seizures with during the fever, child intake, food intake is become less, and they have the hypoglycemia. Hypoglycemia leads to seizures. So every fever fits is not the febrile seizures. So with this case, we learn that point. So this is all about the febrile seizures. Take home message is every fit with the fever is not a fever fit. We need to evaluate thoroughly to rule out the like our hypoglycemia case or CNS infections. If any red flag signs is there, we need to evaluate thoroughly. And is that this is the febrile seizure diagnosis is by exclusion, and history is very important useful thing, and avoid unnecessary EEG or imaging. So go through the recommendations. We need to follow the recommendations to do this investigation. Find out the risk factors, which is the very important in this case of febrile seizures patient, to prognostic and counseling of the parents. Midazolam nasal spray will useful, but very cautious. So before advising the midazolam nasal spray, we need to demonstrate to the parents how to use this. Try to avoid eptan and carbamazepine in case of if you're planning for the chronic therapy, and avoid mefenamic acid and antihistaminic nasal decongestion. These can reduce the seizure threshold and cause the recurrence of febrile seizures, and identify the risk factors for Dravet syndrome. These are the take-home messages from the my class. So overall, I am going to tell about that any febrile seizure or simple febrile seizures is two things. One is try to find out the other causes of the seizures. Second thing is proper counseling to the patient with the following the major and minor risk factors, and recurrence of risk of epilepsy and recurrence of uh, risk factors for recurrence of the further febrile seizures. These 4 points we are going to discuss with the parents before advising for the any intermittent or chronic therapy. So this is all about the febrile seizures. Thank you.